Welcome back to our educational video series. It's time to put all your knowledge that you've learned to the test. But before we get started, let's review some of the most common reasons our VAD patients will call 911. Shortness of breath, heart failure, left or right, sepsis or infection, bleeding, gastrointestinal distress, epistaxis, cardiac arrhythmias, or ICD firing. It's important to note that not all of our LVAD patients have an ICD. However, with or without an ICD, lethal arrhythmias will stop the RV from filling the left side of the heart and/or the VAD, decreasing your cardiac output. You want to place your patients on an EKG monitor and treat them per ACLS protocol. Other reasons they may call is stroke, falls and syncope, hypo and hyperglycemia, dehydration, hypotension and low flow alarms, other device alarms, a severed driveline, which is considered a VAD emergency, and other device malfunction. While not common, it's always important to note that should you be getting a call for a device malfunction, you should contact the implanting center immediately, assess if your pump is running. You can do so by auscultating the left chest wall over the apex of the heart. If your pump is running, you should hear a continuous mechanical sound that indicates the pump is running. And at that same time, you should be assessing the system controller, as it will give you other information pertinent to the patient. This is our new and improved emergency algorithm for the assessment of the unresponsive adult VAD patient. This is meant to be a helpful guide for decision making for a patient who may or may not be unresponsive. It'll help you with your rapid assessment, checking for signs of life. It's important to note that you may not feel a pulse on these patients. For the ICCAC guidelines, we do not recommend the use of compression device, but always tell you to follow the guidelines per the implanting center of that patient. And finally, stow before you go. Always make sure you have the emergency backup bag with all of the backup controller and batteries and other equipment necessary for the patient. Let's move right. Our first case study, you have a 56-year-old male VAD patient with shortness of breath and altered level of consciousness. En route to the patient, you should always be paging the implanting center. Oftentimes, the implanting centers have an answering service and need to page the VAD coordinator on call. This allows enough time for the VAD coordinator to call you back while you arrive on scene and assess the patient. On scene, it is noted that the VAD is intermittently alarming low flow. The spouse reports last known normal of 45 minutes prior to arrival. Your assessment reveals a pale adult male who's difficult to arouse with no palpable pulse. There is a positive VAD hum. Your 12 lead reveals a sinus bradycardia at 38, and the patient has a respiratory rate of 10. There is no Doppler available to obtain a blood pressure, and you're unable to obtain one on the automatic cuff. There's also no pulse ox reading available. However, your end tidal CO2 is 30. So let's review our emergency algorithm. Your patient is unresponsive, but they do have a positive VAD hum. They are having intermittent low flow alarms, but their end tidal CO2 is greater than 20. At this point, you're considered in a low flow unstable state, and you should be assessing for some of these other causes: rhythm, and how you're going to either defibrillate, cardiovert, or pace; volume, maybe they need fluids; consider an inotrope or pressor; search for any other reversible causes, and make sure that all your equipment is set up accordingly. Now that we've reviewed the algorithm, if you guessed that you want to externally pace your patient, you are correct. Now that you are externally pacing your patient, your 12-lead monitor reveals a heart rate of 70, your VAD alarms have resolved, and you can begin transporting your patient to the ER. The implanting center is always preferred, but always make sure to notify the center regardless of where you're transporting them. How can you ensure that you have electrical and mechanical capture? You're always looking for signs of improved perfusion, which includes improved mental status, your VAD alarms resolve, your color and warmth improve, the capillary refill, and your end-tidal CO2 should improve as well. Let's move on to our next case study. You have a 39-year-old female found unresponsive in her yard. En route to the patient, again, you should be paging the implanting center. On scene, you reveal that the VAD is constantly alarming, and the daughter reports the last known normal was 10 minutes prior. Your assessment reveals a pale female, unresponsive, periodic cyanosis with no palpable pulse, no VAD hum. The 12 lead reveals artifact with a heart rate of 76, and you are unable to obtain a blood pressure, and your end-tidal CO2 is 15. Again, let's review our emergency algorithm. Your patient is unresponsive. There is no VAD hum present. They do not have a pulse. You are going to move straight into your ACLS guidelines. Start performing high-quality CPR and all other ACLS guidelines. Again, we do not recommend the use of automatic compression devices, but that is center-specific. So just to review again, this was considered a PEA arrest. You should be beginning high-quality CPR, no automatic compression devices. Follow all your ACLS protocols. During your first round of CPR, you obtain ROSC, your end-tidal CO2 rises to 37, your blood pressure is 60/41. Your VAD continues to alarm, and you note that the driveline has been disconnected. The medical treatment team per protocols and transferred to the ER. Moving into our third case study, you have a 47-year-old female VAD patient who has a past medical history of chronic driveline infection. She called with vague symptoms, but the coordinator had told her to call EMS. En route to the patient, you page the implanting center, and on scene, you note that her vital signs are stable. However, she does have a complaint of a headache that is 10 out of 10 and noted to have some intermittent blurred vision, which she took Tylenol for. Again, let's review our emergency algorithm. Your patient is responsive, so you're going to look for other reasons that might be causing some of her symptoms. So we want to review here is that not all patients present the same. We have our BFAST mnemonic for balance, eyes, face, arms, speech, and time for stroke, and noting the signs of a stroke. Anytime a patient, especially a VAD patient who's on anticoagulation, is complaining of a severe headache, as a VAD coordinator and provider, we're always concerned for potential stroke-like symptoms, and these patients should be transported to a stroke center for evaluation immediately. Fourth case study. You get a call for a 52-year-old female found unresponsive in her house. En route to the patient, you page the implanting center. On scene, the VAD is constantly alarming. However, you note that there's no readings or lights available on the screen attached to the patient. The family reports last known normal was 1 hour prior. The patient is unresponsive, has a faint, palpable pulse. No VAD hum is present. The 12 lead reveals a heart rate of 63. Your blood pressure reveals a mean arterial pressure of 45, and your end-tidal CO2 is 30. You continue to support the patient per protocol, and while assessing the equipment, your patient becomes bradycardic with a heart rate of 32, and the end-tidal CO2 drops to 18. So let's review our emergency algorithm. Your patient starts out a little bit more stable. However, they move straight into this unstable area where they have no flows. So the hum is not present. So there is something wrong with your pump. They do have a pulse. However, their pulse becomes faint and their end tidal CO2 is less than 20. So it moves you back straight into this high quality CPR ACLS protocol to support your patient. You begin high quality CPR. You follow ACLS protocols. You note that the constant VAD alarm is still present. The driveline is connected, however, the batteries are completely depleted. While one team member is performing the CPR, another team member should be doing the assessment of the controller and all the external equipment of the VAD. You connect fully charged batteries, and your VAD, while it continues alarm, now the controller displays low flow call. You obtain ROSC after 2 rounds of CPR, and the charged battery is attached to the patient. You continue your medical treatment per protocol and immediately transport that patient to the implanting center and notify the team if you haven't done so already. Our 5th case study is a 58-year-old male having LVAD alarms. En route to the patient, you're paging the implanting center. On scene, you find that the VAD is intermittently alarming. The flows are showing anywhere from 2.4 to 3.1. In order to stop the alarming, you can hit this alarm silence button, and next you can toggle through all of your settings using the circle and square button, or what I like to call the toggle button. As you click through, it's going to give you all of your readings, the speed, the flows, which you note are low, the PI, which is noted to be high, and your power. So let's review our emergency algorithm. Your patient is awake and responsive, however, they are having low flow alarms. Again, you're going to be searching for reasons that could be causing these low flow alarms for that patient. So let's review some of the reasons that could be causing low flows for a patient. Hypovolemia, bleeding, cardiac tamponade, right ventricular failure, hypertension, arrhythmia, pump thrombosis, or outflow graft occlusion or obstruction. When you're looking at how the pump is situated, you see that the blood flows in, it spins around the pump, and goes out through the outflow graft. Occasionally what we see is that there can be some sort of occlusion causing compression on this outflow graft that can then cause low flow alarms. What we have found is that there's a buildup of what, lack for better terms, we call schmutz in between the graft and the outside of that graft, which then causes compression, causing low flow alarms. You want to transport to the VAD center for evaluation. Always use the measurements that you have. The VAD readings will give you clues to what may be causing your low flow alarms. A lot of times with an elevated blood pressure, you may have low flow alarms. This can be seen even without a blood pressure when you have a low flow and an elevated PI or pulsatile index. You want to treat the blood pressure. If your alarms don't resolve with afterload reduction, you want to return to your differential for other causes for your low flow alarms. But let's talk about IV fluids very quickly. Should we or should we not give IV fluids? Oftentimes, it's one of the easiest things to give, assuming that the low flows are always caused by some sort of low flow or low volume state. However, what we know now is that low flows may not be caused by dehydration. Patients with heart failure are very sensitive to preload. If giving volume, always start with small amounts and give it slowly over time. In summary, increasing numbers of patients are now being implanted with LVADs. Automatic blood pressure cuff and pulse oximetry are unreliable in non-pulsatile VAD patients. We do not recommend the use of automatic compression devices. However, we tell you to defer to your implanting center's protocols. It is important to note that not all calls for a VAD patient will necessarily be VAD related, but you should always be checking that VAD to make sure that it is functioning appropriately. Partner with your implanting centers to increase your awareness and to get familiar with their protocols and guidelines and/or for additional education and hands-on training. ICCAC also has developed field guides to assist with EMS providers, as well as an MCS emergency app that are useful resources for training and while out in the field. We hope you've enjoyed this educational series. Please again reach out to us with any further questions at iccac.global. Thank you.